Good afternoon, everybody. My name is George Mann, and we have a exciting session today with Ron Skaggs introducing Rachel Knox. Ron is the Chairman Emeritus of HKS and a stalwart supporter of our program, and has credentials that you wouldn't believe. So I also see another credentialed person, Harold Adams. Welcome, Harold.
I left my class out early just to attend this lecture because
That's
it's
fantastic. Thank you. That was so nice because I thought in Aggieland often the Thursday is a Friday, but they outfoxed me. Friday is Friday tomorrow. So, but I'm cutting into the time. So, Ron, would you take that over? Oh, one last thing. Harold is the retired Chairman Emeritus of that tiny firm called RTKL. About, I don't know how many people he had all over the world and X number of offices. So it's always nice to have Harold and Ron here and all the rest of you. So Ron, it's your ball game and I'll be quiet.
Thank you, George. And it's truly a pleasure for me to introduce our lecturer today. She's Rachel Knox, a principal of HKS Architects in our headquarters in Dallas, Texas. She's also the Director of Health for the Dallas office and is a pediatric practice leader for HKS, responsible for assisting in the overall design direction and planning issues for the firm's pediatric health clients. Rachel works to fulfill the owner's and ultimately the end user's project vision, working with her clients to improve their operations through the design. Rachel collaborates with the entire team to monitor project progress and costs, maintaining work conformance with project schedules and budget requirements, and she's involved all the way through. She continues her support even into construction services to see that the intent of the working drawings and the client's needs are satisfied. She's a hands-on architect. I'll just put it that way. She's designed a lot of facilities, so I'm not going to go through all of them, but I just might mention a few. Some of her clients include Children's Healthcare of Atlanta, the Children's Hospital and Women's Hospital for the University of Michigan Health Sciences Center, Phoenix Children's Hospital, the Benjamin Russell Hospital for Children in Alabama, Birmingham. Here in Texas, the Texas Scottish Rite Hospital for Children, Akron's Children's Hospital, and Our Lady of the Lake Children's Hospital in Baton Rouge. She's a member of the American Institute of Architects, the U.S. Green Building Council, is KDAC accredited in evidence-based design, and many other accolades that I will not spend more time on because I want to give her time to share her knowledge with the students. So Rachel, I'll turn it to you and welcome to this lecture series.
Thank you so much for having me. First of all, can everyone hear me okay? Just a nod,
Yes.
Okay. I'm going to go ahead and share my screen.
While she's doing that, I might mention that the title of her presentation is Specialized Health and Hospital Facilities, Women's and Children's Health Facilities. Well, it's on the first screen here, as you can see.
Yeah, let me adjust my settings a bit here. Okay. So please feel free to pipe in as we go if anyone has any questions or if we have audio issues, et cetera. I know we're all pretty adept to working in a Zoom world at this point. And I guess, George, do we have until 12:50 or 1 for this? I had two different times on my calendar.
Why don't you take on 50 minutes from now? That would be about 12:53
Okay.
and 10 minutes. We don't have a real hard stop, but they do have other classes and things to do. So let's think of about an hour total.
Okay, sounds great. All right. Well, we have a lot to cover. Brian and I were chatting about this, and he said that the floor is yours to kind of share what you want to share related to women's and children's facility design. So that's kind of a tall order for me because it's something I'm very passionate about and have built my career around. So I certainly have a lot to share, but I've tried to distill it down to maybe some high points. George has a copy of this presentation. So if there are topics that you want to delve further into, I would be happy to provide my email address and send additional resources. Really, we're probably just going to scratch the surface here. Did you say something, George?
Oh, Joe Sprague just joined us on my phone, so I'm gonna, that was
Okay.
it.
Hey, Joe. All right, well, we will jump right in. Hold on. There we go. Okay, so we'll spend a few minutes with a sort of a general introduction. I wanted to spend some time for those of you who might not be familiar with just kind of why do women's and children's get lumped together in terms of healthcare design. There are a lot of overlapping factors there that I thought we might kind of start by discussing, and then share some things specific to designing for women's services, and then some specific to designing for children. And then we'll have some time at the end for Q&A. I will try to keep my eye on the clock as well, so we take full advantage of the full hour. I also have to give a disclaimer. There's a lot of text on these slides. Normally, I'm not a fan of a ton of text on a PowerPoint, just for graphic reasons, but I know that this might be shared afterwards. So I wanted to make sure that it was somewhat standalone. So just thought I'd give a disclaimer. So a little bit about me. In addition to what Ron just shared, I've been at HKS. June will mark 19 years. So I have spent my career here. I did do an internship in college at HKS, which kind of led me back here for my full-time job. I graduated from Louisiana Tech in North Louisiana in 2002 with a Bachelor of Architecture degree, and made my way over shortly thereafter to Dallas. I've been very fortunate to have landed right in healthcare and kind of found my niche in pediatrics, and then also women's shortly thereafter. As you can see on the screen, I feel like I need to point out that I am married to an Aggie, if that hopefully gives me a little bit more street cred with you guys. So Travis graduated a few years before I did, and he would like to say that we're also raising two Aggies, because I don't think he's going to entertain them going to any other school. So just to give you a little context, I'll probably make reference. I am a mother of two, so we have a 3.5-year-old and an almost 6-year-old. So I certainly has kind of refocused my lens as a parent and as a mother who has delivered 2 children herself. My disclaimer, though, I told Travis, my husband, I would stick this in here. On the day that A&M plays LSU, I do give my loyalty to my home state. So, but other than that, I do pull for the Aggies. Okay, so a little bit about HKS. As a lot of you guys are probably aware, because I know we do a lot of work with A&M, we are a good majority of our business is in healthcare. So that is one of the market sectors that we do a lot of work in. Within the healthcare practice, though, a lot of our work effort is focused on women's and children's facility design. So those are specialties of ours. This slide is actually a couple of years old. I probably need to update these stats. I realized as I was pulling this together, but this is representative just of our national work alone. And we have international women's and children's design work on top of that. So just a little bit, I know you guys in this semester are studying kind of the continuum of care. So looking into a lot of different areas of healthcare design. So as I mentioned, why do we group women's and children's together? Why do you hear those, kind of lumped together so often? So this is by no means an all-inclusive list, but oftentimes women are the family decision makers on healthcare. Think about your own family. I know my mom chose where we would go to the pediatrician. She would choose it when I needed ear tube surgery. She did the research and kind of made the calls on that. And we find that that is very common across all families, that even as families age and, husband and wife, oftentimes women stay as the decision maker for healthcare. So they're very wed to the healthcare of the children and kind of where their children seek care. There is a lot to do with both of these areas in terms of brand loyalty, which equals capturing market share. You know, healthcare corporations are businesses, so they're interested in making sure that they are servicing as many people, you know, within their population reach as possible. Women of childbearing age and pediatric patients typically fall in the same demographic. So when you are, you know, when a healthcare organization or health system is targeting growth in a specific area, this is oftentimes, if they can grab the women of childbearing years, they can also grab the children that will come out of those families. And then, of course, once we get into the hospital itself, labor and delivery has a very close relationship and proximity to the neonatal intensive care unit. So should those children, those babies need care immediately post-delivery, there's a very close adjacency need there. And then even with a healthy baby, for those of you who may not be aware, but when you deliver in a hospital, you're seen within hours by a pediatrician, even for a healthy baby, and you'll be seen several times. So there's a lot of overlap between those two services, which then kind of segues into them being grouped together in a lot of design thinking. And then, of course, there's the appeal as a consumer for a one-stop shop. That kind of goes back to the other bullet point on brand loyalty, that you want to, you know, think, well, wow, I can align myself with this particular hospital or this particular group of physicians, and should I need other care, or should my children that I deliver, you know, at this facility need other care, then they can also provide that too. So I'm identifying with kind of one location or one system. And then I think, of course, I'm quite biased, but I do think women's and children's healthcare are extremely dialed into patient family-centered care principles. It's something that's of the utmost importance to them. So just to dive in, expand on some of those bullet points a little bit more, one of the trends that we're seeing is with pediatric health systems, which tend to be very regionally focused, is a growth into the communities. A lot of our repeat clients that HKS has worked with, Children's Health here in Dallas is a good example, or Cook Children's in Fort Worth, are looking into building their next wave of hospitals out in the community. And when we do these demographic studies, we talk about new rooftops. Why do we talk about new rooftops? That tends to be a sign of where new families are settling. So you think about, you know, maybe where some of you guys are from, and those sort of newer suburban areas, they have, you know, maybe starter homes or great schools, or the things that tend to attract young families. The hospital systems study this. So, you know, kind of touching on the point I made about demographics, you know, if you look towards where these new rooftops are, you're likely to find a lot of women of childbearing age, and then also your pediatric patients along with that. I think it's important with both of these communities, both women and peds, that we know who we're designing for. These stats on the screen I pulled from a pursuit that we were part of, where we really wanted to know, you know, who's this particular demographic that's going to be giving birth at this new hospital, because this really informs the way that we approach design. And then similar with pediatrics, you know, there are a number of factors such as obesity rate, you know, access to healthcare, that are determining factors to how healthy patients are going to be when they show up at the facility. So that is a very important, before we get started in design, to just know who's our target audience here. Branding and identity, as I mentioned, are very important. You can probably just take a glance at the screen and figure out which one of these facilities comes from a lobby of a women's hospital and which one comes from pediatrics. I think these are two areas of design where we really borrow our cues very strongly from the populations that we're serving. So the example on the left-hand side of the screen is Florida Women's Hospital. the design team was very deliberate to borrow very feminine and organic cues to inform the design of that facility. The color palette is very soothing and soft. The furniture is even maybe a bit more feminine, as well as the artwork. So you can kind of just glance at the picture and sort of see who might be using that facility. And then likewise, the image on the right side of the screen is from Texas Scottish Rite, their Frisco campus, where we really played up, playful colors, lots of movement in the form, fun spiral staircase, great arts installation in the atrium space. But I think being able to use the design to evoke a system's brand and to speak to who you're serving is something that's especially unique to women's and peds. Of course, wayfinding and security. I have an image on there. That's one of the infant security systems that we use. But I think both facility types are very dialed into security needs. Given that they are, have little babies and lots of visitors that are in and out. So that's something that we're especially attuned to with women and children's design. And then I think, also designing for the entire family. I know that every hospital, every, assisted living facility, every mental health facility is going to have some degree of visitors that they need to anticipate or some degree of family support. But I think that this is just especially true for women and children's facilities. You've got to, when you're thinking about designing that OBGYN exam room, you need to make sure that it's wide enough to get a stroller in, because those postpartum moms are going to be bringing their newborns with them. You need to make sure that your lobby in your children's hospital can accommodate large families that are going to come. Even in with COVID, with visitor restrictions, we saw that children's facilities were one of the very few facility types that still allowed, even at the height of COVID, the height of some of those scary volumes that we were seeing, they would still allow one parent at the bedside. And most of those, I know, at least in the Dallas-Fort Worth area, as of this week, are opening up back up to 2, which I am very encouraged to. I think that's a sign that things are hopefully headed back in the right direction for us. So jumping in a bit on, designing for women's services. So what specifically are we looking at when we kind of tackle the design of a women's facility? Again, I mentioned this, but want to capture market share. When you think about it, women, I think like when I first moved to Dallas, I wasn't married, but I knew there was a good chance that the doctor that I established myself with, I would be with for years. So I wanted to know, tell me a little bit more about this facility. This is theoretically where I could give birth one day, So women have a choice when they're choosing their physicians and they're choosing the facilities that they will give birth at. And this is pretty unique. Most people end up at the hospital, and they end up at the hospital, either because that's the one place that offers, specific care for their condition, or they come in through the emergency department. They have absolutely, it was an emergent reason. But I think women have a decision to make, and the facilities know this, and they want to look to design features such as a convenient location, providing spa-like amenities. A lot of soon-to-be mothers, myself included, don't view themselves as patients. I didn't view myself as someone sick that needed to be handled with kid gloves. I wanted it to be a great experience for myself and for my family when I did give birth at a facility. So a lot of these spa-like amenities really speak towards that population. Providing ample views and natural light. So that kind of also, is in keeping with what we try to do in all healthcare facilities. But if you think about creating more of a hospitality versus a healthcare experience, that is very important. And then providing a full complement of services. So, if you are a mom and you know that you're going to, that breastfeeding is going to be very important to you, you want to know that they have a really solid lactation team that can counsel you and can help and assist with that. If it's, when you're choosing your doctor, the facility I delivered at has a very good breast health center. So as you get into your middle ages and you need to have a mammogram every year, just knowing that they have that full complement of services is very important, as well as great pediatricians that can also see your children, whether it's a women's and children's hospital where all of that is mixed, or just good synergy between those two groups of physicians within the community. And then educational opportunities. One of the things I loved about, and just to give them credit, I delivered at a THR facility, but I love that I could, under one roof, I could go to car seat training. I could, my husband and I did infant CPR. We did a baby basics class. I did a breastfeeding class. So knowing that you can have that very kind of holistic approach to preparing you for motherhood, or even post motherhood. I know THR has some wonderful offerings for families in terms of educational offerings, and then brand recognition. That I don't think you can understate that, especially here in Dallas, in a large urban community. There's a certain amount of pride with delivering at a hospital that that has good brand recognition and a great reputation. So campus and building organization. So once you've decided where you're going to go, thinking about designing for convenient outpatient access within women's, kind of the arena of women's healthcare design. A woman can be in her clinic setting for an appointment and emergently have to go into a hospital setting. So the convenience of getting those outpatients in and out, but also the proximity of getting outpatients into the hospital is very important. So those two worlds are very closely tied together. Easy wayfinding for patients and visitors. I think having a baby is one of those opportunities that literally everybody in the next door neighbor drops by. So thinking about how you're going to get them to where they need to go and to provide that clear direction. And then you want it to be welcome, but as I mentioned, very secure. I love the fact that, knowing that there were security measures in place. So even a couple times that my kids left my site when we were in the hospital, I knew that there was no way they were going to leave the four walls of the hospital because of their security tags, because of controls that were on the elevators and stairwells. So when you're designing, that's something that we work very closely with our technology consultants to make sure that we've captured that and coordinated it. Identifiable location for OB triage. So when we're talking about, these, it's time to give birth. That can either be a scheduled visit, or, so again, I told you I would draw from my own experiences. My first son, I had a pretty quick labor of 7 hours. My next one arrived within an hour of when I woke up at 12:30 at night. So I definitely got to experience both the normal scheduled arrival and the emergency arrival to the hospital. So making sure that that is clear and distinct for both of those patient populations. And then reducing the number of times the mom and baby have to move. I'm not sure how much you guys have gotten into it, but one example of that is there's a labor delivery recovery, which is probably the most common model when we're talking about labor and delivery, where the mom labors, delivers, and then recovers for a bit in the same room and then moves on to a different postpartum room. And then there's an LDRP model where the postpartum happens in the same room. And the goal with that is to reduce the number of moves. So I think just thinking about how we can make that process a little less chaotic for mom is important. And then the NICU relationship to labor and delivery. There are instances where a mom that's in labor, you're going to know already that baby, either they're coming early or there's something that's been diagnosed in utero, that that child is going to need NICU services right away, or sometimes it happens very emergently. So you want to know, that there's a NICU close by, that there's a qualified team on standby waiting to help should you need it. So as you're designing, thinking about that relationship of labor and delivery, very close to NICU, I would say within healthcare design, that's one of the paramount adjacencies that we need to be providing for as we're looking at blocking and stacking our buildings. Patient and family-centered care. So this is the idea, and there is a patient and family-centered care organization, International Patient and Family-Centered Care Organization. I would encourage you guys to maybe research this, look into their website. They have a lot of great resources. But this is the idea that a hospital should not just be treating the patient, they are treating the family. And not only are they taking care of the family's needs, but they're also need to be very welcoming to the family. They view the family as part of the care team. So this is very important. It's also important that as we're designing that we look at supporting mothers of all ages or all experience levels, if you will. So the first time mom is going to have very different needs from a mom that's maybe there for, to deliver their, third or fourth child. Accommodating alternative birth plans. Some moms may choose, as I did, a medicated, assisted delivery. Others may choose to go more the natural route or use a midwife or a doula. Some facilities support water births or some of the more natural laboring methods. So you really have to, as you're designing these facilities, you have to understand what's being supported by the system. And again, it goes back to the other slide I talked about what is the community asking for. So what kind of demographic are you dealing with? And that's going to start to provide some cues in terms of what the hospital needs to provide to satisfy what they're looking for. Giving control to the patient is very important. This is also a way for the patient to feel like they have some say in their care plan. In addition to creating that hospitality environment. So providing control of lighting, temperature, sound, being able to darken the room, being able to make things very quiet. And that overlaps into the next point of, this is kind of an exhausting thing. Giving birth is it really takes a lot out of you. So having some ability to have some quiet time postpartum. A lot of these facilities will be designed. It's kind of one of the few areas in health design. I take COVID out of it. That does have some visitor restrictions. I know a lot of the women's hospitals will say, okay, these are our quiet hours, and this is so the hospital can say, sorry, you're gonna have to come back at a different time, and doesn't put the new mom into being put in the position of saying no and turning down her visitors. So, and the reason why I mention all of these to a design class is it's very important to understand what kind of operations you're designing to so that the design can support that. I think my next bullet point, I apologize, got cut off. That was rooming in. So that's the concept that we've kind of gone away from the traditional nurseries where every single baby goes back to the nursery for a period of time during the day and at night, and rooms in with mom instead. This allows, the theory behind that is this allows mom some time to bond with the infant. It also facilitates and helps improve breastfeeding rates because babies want to nurse frequently, and getting it right those first few days are very important. And again, the reason I mentioned this to a design class is because that sort of informs where the balance of space goes. So what we've seen is that the rooms where moms are staying are getting a little bit larger, and those traditional nurseries are getting a little bit smaller. We still are required to provide the nursery, and a lot of moms still choose to use the nursery, but I would say the rooming in model has really kind of reinformed the way that we allocate space. We also need to be aware that these facilities are supporting very complex patients. There's a lot of high-risk OB that could be due to a mother's age. Could be pre-existing conditions, obesity, diabetes. There are a complicated past birth. Another factor that is being seen across the board in this country is women are waiting to start their families. They're waiting to get their careers established. They're waiting until they're financially ready to start a family. So with that comes some increased risk, although I would, as a geriatric mom myself, I would say that I think some of that is a bit over exaggerated, but certainly as you increase the overall age of childbearing population, you will incur some more risk as well. Another phenomenon, probably not the right word, but another factor, I guess you could say, that we are dealing with quite frequently as we're designing women's facilities and NICUs as well, is neonatal abstinence syndrome. So these are babies that are born addicted to, with the opioid crisis, addicted to whatever substance that their mothers may be addicted to. So these babies have different needs. And then, as you can imagine, there are some issues that need to be addressed with the mom, the overall health of the mom, or also just some of the social work, being able to observe the mom more if you need to. So this NAS is really always a factor of discussion. And I would say it does not discriminate. It is not, unfortunately, it's not a syndrome that we only see in poor communities or communities with high rates of drug use. It's kind of across the board. Also interdepartmental collaboration. So should one of these complex patients need to go to surgery immediately after delivery, or should they need imaging facilities, or should they need to be seen by a consulting physician from another specialty, we need to be thinking about how all that interdepartmental collaboration is working between all of the different components in the hospital. And then one new trend that I want to mention is called couplet care. This is something where HKS recently completed a hospital, Cone Health in North Carolina, and they have a couplet care model that's been very successful. But this is basically where you can take care of a sick baby and a postpartum mom in the same room. So instead of moving those two groups to two different areas in the hospital, you bring specialists in to take care of them in the same room and keep mom and baby together.
George, I think it's Greg Koenig is where all the noise is coming from, if you're able to mute him. Sorry, Rachel.
Oh, that's okay. Yeah, I was hearing a little bit of background noise.
Didn't have a sync that would have worked. I think they just found this one easy. I don't know, but
okay.
It seems odd that we're now
using a
product out of Helsinki, Finland, when it's melted plastic. I mean,
Professor Mann, you're muted, but you can make me the co-host and I can try to mute them.
I think I got it.
Okay. Yeah, it sounds better on this end. So, and then finally, we also want to be thinking, how can our design, and this is a pretty powerful statement, but how can our design support a healthy community? Which is really kind of awe-inspiring when you think about it. That's something that we do as architects, can sort of be the catalyst to really increase and raise the health of the community as a whole. So it's probably no surprise, but a healthy pregnancy equals a healthy baby. So all these things that we're doing to take care of mom are improving the outcomes of the children that they're having, providing those educational opportunities. So it doesn't even necessarily have to be related to childbirth per se, but I mentioned, CPR classes, healthy cooking classes, even some facilities often offer, infant swim safety classes. So there's a lot there that, the hospital can provide that really starts to be a catalyst for a healthier community. Increasing breastfeeding rates, there's a ton of evidence out there on the benefits of breastfeeding, and really the success of breastfeeding starts in the hospital in those first few hours and days after birth. So the hospital has a lot that they can do to impact that, and we need to be mindful of that. Those are questions we need to be asking when we're designing these spaces. But cooking and exercise classes, and of course sustainable design. We don't want anyone to get sick from the building itself. In fact, there are things we can do to make them healthier. So we definitely need to keep our eyes on sustainability as well. And then providing beyond that, I've talked a lot about childbirth, but obviously related to women's services, there's a lot that happens before and there's a lot that happens after in a woman's life. So providing that full complement of services from adolescence all the way to end of life. So before I feel like I've just been yammering on and on, any questions so far before we jump into pediatrics? All right, well, maybe we'll have some towards the end there. But these next few slides are more specific to how we design our hospitals for children. So again, here's the same comment I mentioned of patient family-centered care. This is extremely important in the pediatric realm as well, providing care for the entire family. Pediatric patients also, they're going to require a higher level of supervision and also have increased visitors. So with these families that you're welcoming to the bedside, you just need to be mindful of those two factors as well. And that you're going to be, I worked with a chief nursing officer in Indianapolis, and she was a very, very seasoned nurse, had grown her career from the bedside up to an executive level. And she said, when my daughter had ear tube surgery, she said it was like I didn't know a thing about healthcare. I was so nervous for her and nervous for us. And she said all of my, preconceived ideas that, oh, you should only, for a minor surgery, you should only bring one family member. I had the whole gang there for that. So even for something minor or a lower acuity health event, you have to expect that these children are going to have a lot of family support at the bedside. Pediatric illnesses don't discriminate too. That's something else to keep in mind. And if you were to visit, as I mentioned, a lot of children's facilities are going to in large urban centers, they're going to have a very wide draw regionally. And what you find is you're going to see all walks of life. There's nothing to say that a child born from, a very wealthy household is not going to have a congenital heart defect. That's not going to, or a family that's very healthy is not going to have a child that develops some type of unusual pediatric cancer. So you're really going to see all walks of life, and you're going to see everybody, every group in the socioeconomic spectrum has been impacted if you were to walk around a children's hospital and kind of look at who they're serving. And then finally, whatever we can do through design and operations to decrease a parent's stress is also going to decrease the patient's stress. That's true for all patients, but especially for pediatric patients. And, just think back to times of, maybe when you were growing up and you saw your parents going through something particularly stressful, not even a health issue, but just, maybe some moment in life that you knew they were stressed out. And we all take on that stress for them. We might not understand it, but we all take that on. So of course, in a hospital setting, that's going to be detrimental to a child's recovery. So we really want to make sure that we're doing whatever we can to remove some of that stress for the families so that the kids have one less thing to worry about. Frequent flyers. This is a term that you hear a lot in healthcare design when we're designing children's hospitals. And this is the idea that a lot of children, whether they are born with a congenital defect or have some type of, cancer that's going to require years of surgeries and different kinds of treatment, they are likely going to be in and out of the hospital throughout their lives. This is true for a lot of pediatric patients, and they're going to be bouncing between outpatient to inpatient and then back again. So the other thing that we find is the families become very savvy and they are very fierce advocates for their children's care. I had a family focus group meeting. We did some mock-ups in Plano last week. And at the end of the day on Thursday, we invited the families to come and tour the mock-ups. And these families, they just always impress me with, they know more medical terms than the staff we were meeting with during the day. And they're rattling off things about monitor placement and different alarms and, the quality of light they're expecting to see at the bedside. They really do become a very savvy customer base. If we're thinking about who are our customers when we're designing, the families are absolutely, and the patients. We need to be thinking about them and reaching out as we can. And a lot of the children's hospitals that we work with have really great patient and family advisory committees that we've gotten to work with. And then positive distractions. So this is the idea, and I just threw a few on the screen. But what can we do with design, with interior design, with exterior design, with technology that can take a patient's mind off of something scary, something stressful, or even something painful, and sort of transport them to a different place? You know, so you can see we do a lot of that with color and light, as you can probably see from some of the examples I've shared there. We also will use artwork as a positive distraction, or technology. So the image on the right-hand side of the screen is at Children's Healthcare of Atlanta. A lot of you guys have probably been to buildings, hospitals, or, you know, along with that have donor walls to kind of recognize everyone who's given to that particular facility. Well, sometimes those are kind of static and boring. This one was, we were able to print all of the donor names on clear sheets of acrylic, but behind it we had a virtual aquarium. So the kids could go up and push a button that they wanted a sea turtle to swim by, and a sea turtle would swim by, and they could kind of chase the sea turtle down this long wall. So looking at how can we take something maybe mundane and turn it into a design opportunity and something fun that can serve as a positive distraction. That image on the bottom left-hand side of the screen is one of my favorites. That's from the University of Michigan, from CS Mott Children, that we were in the midst of design. They were in a very old facility, obviously, because they're about to get a new facility. And one of the oncology physicians said, you know, I like to, as long as my kiddos, as long as their lab counts look good, I like to encourage them to get out of their room and walk the halls and start to feel normal again. He says, I have a little basketball goal that I hung at the end of the nurse station. And if they're feeling up to it, that's kind of how I entice them out. I'm like, let's go shoot some hoops. So we worked with 3Form, an acrylic spender, and designed this swirly ball tube where they could, you know, have a more proper game of basketball or, you know, just play ball out in the hall. So that was something that, you know, came from a great idea that a physician had. But we as a design team said, well, wait a second, we can make that a little bit better. So I think that is a challenge, but it's one of the funnest challenges, is how can you take some of these great ideas and really turn them into something that can improve the experience for the patient. Amenities, this is probably no surprise, but we need to be providing quite a few amenities in children's hospitals. So, you know, thinking of, first and foremost, what do we need to provide that they can maintain as much normalcy as possible? So, you know, how are we supporting their school routine? How are we supporting if the family chooses to take meals together at the bedside? How are we supporting that? Where are they playing? If, you know, maybe they can't even get out of their room based on whatever's going on with them, but what opportunities they have for play at the bedside, and how can we facilitate that through design? This is a stressful time, probably no surprise, but I would imagine my kids have fortunately both been very, very healthy, but I can imagine that this would be the most stressful thing that a parent could go through, would be having a child in the hospital. So thinking of how do we offer escape, respite, the ability to reconnect to nature and just decompress for either the child or the parents. You know, so looking at those opportunities of incorporating natural light, incorporating quiet places, incorporating outdoor places. The project that my team is working on in Plano right now is an 8-story bed tower, and we're going to be able to capture some terrace space on every floor of the new tower, which we're really excited about, and the families are really excited about. Family laundry, vending, and meal prep. So again, those are all spaces that, you know, they're not required by code anywhere, but we really, if we're going to be providing the families with as normal of an experience and just allow them, I mean, imagine something so basic as you're stuck in the hospital without a change of clothes and being able to wash those clothes. You know, I mean, that is something very simple that we can provide with design, but that is transformative for that family that would get to wash their clothes. And then how do we give choice and control back to the patient? I mean, think about how scared they are. And the ability to, I've even had nurses tell me, when I go in and give meds, I might have 8 meds, but I let the kids decide what order they're going to take their meds in. Do you want to take the yellow one first or the blue one? Let's wash it down with this one. She says, something even as simple as that can make them feel like they have a little bit of control back that when everything else has kind of been stripped away in this new environment. And then, of course, you're designing for a range of ages. I know this image is a bit pixelated, but it's one of my favorites. The guy there in the blue t-shirt is one of our patients that we worked with for Riley Hospital in Indianapolis. He's a cancer survivor, and he is standing beside an Indianapolis Colt. So he is the size of an NFL player, but he's a pediatric patient. So we have to think we're designing from those little micro preemies that are born early in the NICU all the way up to 18 plus years of age. So the design really needs to appeal from toddlers to teenagers. And you're not going to know from one day to the next who is going to be in that particular room or using that particular space. So it has to transcend a lot of different age groups and really have a broad, timeless appeal. For that reason, we try to avoid themes a lot. So we don't want to put Mickey Mouse all over the walls because that's going to, maybe appeal only to a limited age range and kind of be a major turnoff for some of the older patients. Along with kind of the obvious design implications of designing for a range of ages, supplies, equipment, and medication is also going to be impacted by this. So we're not just storing 3 sizes of bed in the equipment storage room, similar to what you might have on an adult hospital. We're storing cribs, we're storing isolates, we're storing bariatric beds. So we really need to be thinking through that. And our supply rooms are larger because we're storing, everything from face masks that are this big to face masks that are that big. And that takes up more space. Another big trend that we're seeing, and this is good news, is a lot of children that are cystic fibrosis and congenital heart defects, conditions that used to be a death sentence, quite honestly, when you were diagnosed as a young child. Patients are living well into adulthood with some of these conditions, but they're still being seen as pediatric conditions. So we have a growing number of this growing segment that is being seen in the Children's Hospital that are really ages 18 through, say, late 20s. We call that the adolescent and young adult, or AYA, is kind of how we abbreviate that in the industry. But we have to design then for yet another demographic that, some of these parents, we did a facility in Fort Worth, an oncology facility for an AYA population, and some of them have kids. They're bringing their own kids to this facility. So, really, again, being very mindful, who are we designing to, or who are we designing for, and what are their individual needs? And then, of course, just the general design aesthetic. We want these facilities to be very, one of my clients used the term once, timeless whimsy. So we want it to be fun, but we also don't want it to date itself or to feel like it's designed for a very juvenile audience. But it still needs to look like it's designed to be fun and playful. So color, light, a lot of times, what are we doing at night to light the exterior of the facility? Using colored glass, using sculpture, using abstract form. You can see the tree there in the middle in that lobby space. And we actually got feedback from a patient. We had a very abstracted tree. It was a column that we had turned into, a very, very abstracted tree form. And we presented it to some older patients and teenage patients. They said, well, if you want it to look like a tree, it needs to look more like a tree than that. That's kind of lame. So we had to go back to the drawing board and tweak the design of the tree to make it a little more tree-like. So getting that feedback along the way is very important to make sure that you're hitting the mark. And I think this is my last slide, but really we want the design of these spaces to do everything they can to encourage, to help heal the patient and to celebrate recovery. So there's an image there. A lot of times, some of you guys may be familiar with this, but once a cancer patient completes their course of treatment, it's kind of a common tradition to ring a bell at the end of your radiation treatment or your chemo treatment. And we did Children's Cancer Hospital for MD Anderson, and the bell was literally above a trash can. And it was, again, our team saying, we can do better than that. So we were able to bring the bell out, put it in a prominent location, celebrate it with its own space. We put some inspiring super graphics that included some poetry around it, and really celebrated that, you know, this is one step closer in those patients' recoveries, and this is something that should be recognized and celebrated. So I do think, oh no, I do have one more slide. I wanted to include, we challenge ourselves as a design team to say, okay, what are our clients asking us? So this is a recent list that we brainstormed last year that I just thought I would include. These are probably 8 sort of hot topics that our clients are asking us over and over about. I've mentioned some of these already, but just thought I would put it out there and kind of share what we feel is on the horizon, or are problems that we really need to be solving as designers. So creating environments that are designed for those with sensory sensitivity. So those could be kids on the autism spectrum, or kids with certain type of neurosensitivities, that lights and sound, and you know, sometimes some of these great things that we put in hospital, like the piano player in the lobby, can really have a detrimental effect on them. So we need to be aware that we also have that segment of the population. Thinking of the patient and family journey, you know, their journey through the hospital, but also their metaphorical journey as you know, navigating through a diagnosis or an illness. The adolescent and young adult population I just mentioned, pediatric outpatient clinics. So we're really seeing explosive growth in that, especially as more and more things are being able to be treated in a clinic setting versus needing to go all the way into a hospital. Integrating research into design. So you guys are in an academic setting, you know, there's tons of great research out there. So how do we make sure we're taking all that great research on healthcare design and folding it into the work that we're doing in the design studios? Population health, that's what I was talking about earlier, about our abilities of these buildings to really be a catalyst to improve the overall health of the population. And then behavioral health, obviously, is huge. And I think you guys have or will have a class on that, a lecture on that. But that is just an exploding patient population, and pediatrics is not immune to it. So how are we designing spaces that are safe and therapeutic for that population? And then looking internationally. So not just being stuck about what are we doing in the United States, but looking to other countries and kind of borrowing best practices and ideas from what's happening in other countries is another thing that we're continuing to challenge ourselves with. And then that is the conclusion of everything that I had to present. I know I've talked quite a bit, and I would love it if we've got some questions out there.
What a wonderful presentation. Rachel, is that your child?
It is. You know, I had to throw him in at the end.
Well, you know, before you have children, you have all kinds of theories of child rearing, and then you have children and no theories. And I guess it's a he. He looks like a slugger, right?
Oh, yeah.
So it's wonderful. But the way you related, if I were a client and contemplating a children's hospital, the fact that you have children, that you love them and value them comes so through in this presentation. So I can't thank you enough for doing this. And I'd like to turn it back over to Ron, because I'm sure he would like to say a few words, and I'll be quiet.
Thanks, George. I appreciate that.
We can't hear you, Ron.
I have to unmute here. I'm prejudiced, but Rachel, you just brought tears to my eyes. Beautiful presentation. I'm so proud of what you're doing in leading healthcare design at HKS, and particularly the women's and children's sector within that. So congratulations. This is really time for questions from students and others. And unfortunately, I've got to go to another Zoom meeting, so my face may disappear here shortly.
Okay, thanks, Ron. I appreciate that.
Yeah. Rachel, if you could release this so we could, I'd love to see your son, but if we could see the
Yeah,
students all at one time, they can see each other.
absolutely.
And if you want to put on your cameras, we'd be appreciative of that. So let's open it up to students for some feedback for Rachel.
I do have a quick question. First, Rachel, thank you for this presentation. It was truly insightful. And I loved how you touched on both the patient journey in terms of pediatrics as well as women's health, and thinking about design for both of those demographics. But my question was more along the lines of how can we design for the support of the caregivers, just recognizing the demand that we place on the caregivers, and how through designing in both women's and pediatrics, how can we acknowledge the emotional investment that they have with the patients and the demands that are placed on them throughout the day?
Yeah, no, that's an excellent question. And I think you'll find that some of the caregivers that are drawn to this type of care for their career are some of the most selfless individuals that you'll ever work with. And oftentimes you have to draw it out of them. You know, they'll be describing a scary scenario of a, you know, end of life situation that happened for a patient they've been treating, you know, cancer for 5 years. They've gotten very close to the family, and this is what I needed to do for the family. And you have to ask them, well, what did you need? You know, so I think it's on us as designers that if we're not hearing that feedback, that we need to be asking them, well, how can I take care of you? You know, they're not the ones oftentimes that are going to ask when we're in programming meetings, determining how big this is going to be. They're not going to say, I need a quiet room, I need a respite spot, or every nurse station. I mean, this is super basic, but like every nurse station needs a spot where we can keep our water bottles. I mean, you know, just something basic is being able to stay hydrated. We have to kind of stay on top of that as experts and as designers to make sure that we're asking those questions and inserting ourselves so that they're not just glossing over, you know, kind of what their own needs are.
Right. Thank you, because I know it is such a selfless field to be in. And so thinking about how you can design healing environments for both the patients and the healthcare providers is awesome.
Okay, now's your chance, folks.
George, I have a question. This is Joe. Can you hear me?
Yeah, sure.
Rachel, I'd like to ditto both Ron and George's comments about your excellent presentation and all despite the fact that you had that unfortunate LSU experience in a room with a bunch of Aggies, I really think it's really speaks very loudly for the respect that we have, not only for your experience, you know, for many years. I guess my question is basically related to the fact that we all have responsibility as designers to make sure that whatever we design meets all the requirements from Joint Commission to licensure, which brings in things like codes and standards. So I guess specifically, are there anything that comes to your mind that you would like to see changed that limit designers from either OB-GYN, peds, or women's facilities in terms of the goals that you're trying to create, the environments, you know, all the amenities that you talk about is wonderful, pianos and lobbies and color and light and art. Some of the fire people don't think those are a lot of important factors, but we as designers do. So just off the top, is there anything that occurs to you that we might work on to help us?
I think in terms of code requirements, you know, Joe, I've been pretty involved with some of the rewrites for FGI related to PEDS. I've weighed in on some of that. I think that FGI has come a long way in the past few years in terms of now that they have a dedicated section to women's and children's. I think, you know, in terms of guidelines, what we have is great. I do think from state to state, I think some states are better than others about allowing variances when we need them to support a particular standard of care that may be a bit, I don't want to say hampered, but that maybe the code is requiring spaces that they won't use, or spaces that they'd like to use in a different way. I think, again, I think it's kind of up to some of the AHJs and how we interpret some of those guidelines. But I think the FGI has done a tremendous job by just recognizing that that's a separate segment of the patient population. My one thing, I do wish we'd have a definitive ruling on natural light in NICU rooms, but that's just my own personal. I realize that could hurt a lot of projects too, so maybe I don't want that, but.
I think, first of all, thank you so much for that presentation. It was really exciting to watch what HKS has dedicated themselves to, and the perspective you have as a mother also is really enlightening. I think that's great. And on the topic of the FGI guidelines, there are several students actually in this and professionals that are in the audience today that we participated in the Reimagining the NICU workshop with Troy Savage through Mazzetti a couple weeks ago. And that was the topic. We went in with it was a really sensitive group, sort of something I'd never really embarked on before, especially not alongside parents of patients who'd been in the NICU. So it really increased our empathy for the patient, for the parents who are the strong advocates, like you were mentioning. So, and this question is actually also over here, but as far as engaging, these parents of patients in the design feedback and, taking their experiences. And there was a mother that was on our team who actually was like a second or third time mother in the NICU with her children. There was sort of a repeating, issue with what her kids were going through. And so she found, as a first time mother, it was great. She really felt like she had her space. But then when she went in with a 3-year-old and the patient in the NICU, she didn't have the space she wanted, and she wanted the FGI guidelines to change to conform to allow for more family space and things like that. So it was really informing to meet with the parents and talk to them as designers. And I was wondering what that looked like with real world projects like this.
Yeah, well, so my own kind of personal mantra when we kick off a project or even in an interview, I say we will take as much access to your patients and families as you will give us. Obviously, we need to be sensitive. There's, HIPAA and, different, we even have to get them to sign photo releases if we're going to take photos during the sessions. But as much of that as you guys can grab as designers and as much as you can ask for. A lot of times I've had to ask for it. It wasn't like, okay, well, obviously we want you to meet with the FAB. It's like, hey, can we meet with your family advisory board? Oh, sure, you can. You think that would help? So I think some of it's on us to make sure that we're asking for that access. And then once you do have those meetings set up, there are so many, I've been trying to read some of the questions in the chat bar. There are great ways to get that feedback. A lot of times if we're going to be working with patients, we'll ask for assistance from the child life specialist to help create some activities that are appropriate to those patients and their age range to, like art activities that kind of pull out design feedback. If we're meeting with families, oftentimes we meet in the evening, so it's convenient for them. The hospital provide childcare sometimes. Or we'll set up activity space for their kids that they might be bringing along with them. We'll provide dinner. So I think you just have to figure out, like, how do you get them there? And then there are tons of great tools, great surveying information. Bring in the mock-ups. If your project is going to be doing mock-ups is absolutely excellent, because that really helps them visualize themselves in the space and provides good feedback. I think always ask for access to patients and families if that's available. Even in some facilities where maybe it's a greenfield facility and they don't have patients and families yet because that facility hasn't been built in that location, we will do surveying information, or we can meet with surrogate groups that can maybe speak towards just common request. So I think there are a lot of tools at our disposal, but we have to ask for the access.
Interesting. Thank you so much.
Sure.
I'd like to just add a couple of comments. I've known Rachel, what, 10 or 15 years? I can't.
Yeah, it's been a while.
No? Too long?
No. Yeah, no. It's been great, George. It's been great.
Yeah. So, but I've seen you grow. And one particular slide, the health field is like climbing a mountain. And clearly Rachel's excited about it, as many of you are. And when you get to the top of the mountain, you see a lot of other mountains. So in the slide where you talked about the last point being international health, you laid out possibilities within the specialty, a specialty within a specialty. And health is never standing still. So I found that very inspiring because I think you're destined to build on these successes continuously. And I find that as I sit between you and the students, this was an exceptionally inspiring talk. So, and those of you start out and before you know it, you'll be 30, 40, 50 years old. And before you turn around, it'll be over, and find something you love to do. And there's nothing like children. I've got 2 grandchildren that got me wrapped around their pinkies. And but anyhow, are there any other folks? And we also have Perry Harrell from Harrell Associates Architects in Houston, who's also a graduate of your school.
Awesome.
And we're glad to have you. I will be available afterwards because some people have been texting me about the continuing education forum. So please hang on. And I also want to recognize Josiane Tanchou. She's having dinner in Paris. And you get the record for coming the longest way, Josiane, again. Can you hear me? Well, maybe she's having the dinner now.
Yeah.
So, anyhow, the Zoom opens up a lot of possibilities. I was aghast at the idea of it, but I think it may in some ways work better than a classroom because we can pepper the audience with a lot of people that we can't in the classroom. So any questions about anything else? And I would like you to hang on just for a minute. If Madison, are you there, Madison? Yeah, can you show the next speaker on the 9th? And then we'll give a round of applause and then I'll hang around. We have, as members of our Health Industry Advisory Council, a very good firm by the name of Ballinger in Philadelphia. And I've gotten to know them because until last year, I spent 13 summers in Philadelphia because that's where my grandkids are. And they love to come down and talk physically, but they're going to do this by Zoom on Friday, April 9th. So that's an alert to you to come back. And they're a fine design firm. And up and coming is Aaron Cooper, and Lou Milik is really the senior principal of the firm as far as healthcare goes. So having said that, I would like you, Madison, to take that off. And I want to put something on my screen for Rachel and HKS. Brian had to leave. Brian is the new liaison between HKS and us in a lot of things, including the telemedicine project that we're doing. And we're going to invite you back, Madison, if you could extend an invitation to Rachel for the 23rd for the telehealth. So having said that, let's give a real round of applause. And it was great. You inspired me. I think I'm going to sign up.
All right.
I'm going to pick this field. So find something you love to do, and everybody can tell. that you love. You can't fake it if you're in something you don't want to do. So I'm going to hang on for as long as it takes to answer questions. I don't know if Debbie Hart is still here because she wants to ask me something about the form. So have a happy Easter holiday, and we'll see you around. And Harold, thank you so much for what you did with your students. I appreciate that.